But I think that I will, when people are popping into the room, then I will just shortly say hello to all of you and tell you a little about what this webinar is about. You know that Enter have, during the last years, had a vision about inviting young researchers to share their research in order for us in Enter and others to understand what's important for the future and to learn how should we promote research in the future. And this time we also had the idea that it should not only be researchers who should participate in forming the future, it should also be researchers and people with lived experiences who are helping us to understand what is important to make research on. So in Enter, we have some shared responsibilities, and Joe from Scotland, University of St. Andrews, is responsible for inviting to these webinars. And when I emailed him the agenda for today, he simply called this topic today for Nothing About Us Without Us, a slogan all of us know. But today we are going to meet researchers from Italy, from Denmark, from Australia, and from Ireland, who all have to share something in relation to the topic. And what we're doing today is that we are having the presentations one by one, and we end out with having a plenary discussion about the question, which is the topic for today. So we are having a plenary discussion or discussion between all of us about how dialogue with people with lived experiences can help shape the future of the network's collaboration. And based on this question, I want to tell you a little, just 2 minutes, about a new European initiative about this topic. And I will just share my screen. If it's possible to share screen, Jakob, that must be possible somewhere.
Yeah.
Yeah, I have found it. It's just an ordinary team function, so it should be easy enough. And I will just find my presentation. Yeah, so this thing that is happening in Europe right now is a big project, and I'm just making it to a slide presentation. Called Joint Action Prison. It's an initiative where EU want to promote a comprehensive prevention-oriented approach to mental health to support vulnerable groups. And this project is led by people in Spain. And why is this important for us? It's very important because it had to implement and transfer different selected good practices. And in this case, it's good practices about suicide prevention. It's good practices about aging and social inclusion. And it's good practices in relation to child and adolescents, mental well-being. And this is topics that is very important in Europe and I think all over the world. But the thing here is that we have the opportunity in this joint action to have a specific focus on this group. And this is why I'm telling about it today, because what this group have to do is to make a kind of recommendation for how is it possible to involve all people with lived experiences in all the work that is going on in EU and also in research all over Europe. So what we're going to do is to train and support different countries and organizations in this involvement. And this is why I think it's important today, because today is about how this involvement go into research and how can we invite the right people. And I hope that you will help to write in the chat who should we involve. But I have taken this letter of participation and involvement, and the involvement in EU means that we have to do it at the very high level as a partnership, because it's not just as a consultant. So I would like you to know about this project, and if you have any ideas, put it in the chat, because within the next month, I have to go back to the organization and give them advice about who should we invite, and maybe some of you want to be invited. But we know that sometimes it's the best thing is that we know something about roles and responsibilities. How should we work on this case? What knowledge is important? How can we co-produce recommendations for EU for this perspective in the future? And what reflections is needed? Everybody in Europe, there's about 58 partner organizations, are very interested in this because they don't know how to involve people with lived experiences in their work. So I think this was my presentation, but if you want to know more about this program that is just starting right now, you can go and you can follow it on LinkedIn. I'll put that in the chat. And I think the audience we have here today may be interested in following this approach. There will be very many participants from all over Europe, also from countries who are not very used to involve users in their work. So that was just a short introduction about what you also can participate in and what is happening in Europe. But today we have really the lived experiences in this group. And the first presenter I will invite to the screen is Dr. Shaakya Anand-Vembar from Ireland. And you are going to talk about reflections on enacting a novel public and patient involvement process as a lived experience researcher in the VISTA research program in Ireland. So welcome to the screen.
Hi, everyone. Thanks for having me here. I'm excited to present on VISTA and for the first time ever really share my reflections as a lived experience researcher as well. So I'm going to start off by introducing everyone to the VISTA program, which is a national research program in Ireland dealing with mental health. And then I'm going to describe our PPI process as well as our process evaluation of how we're enacting PPI. After that, I'm going to go through some of the highlights and learnings that we've had so far from our PPI process. And then finally, I'm just going to leave you with a few reflections on working in this research consortium as a lived experience researcher. So what is VISTA? VISTA stands for Vision to Action for Promoting Mental Health and Recovery. It is a 4-year research program that officially started in 2024. And it's designed to basically implement Ireland's mental health policy, which is called Sharing the Vision. We are focusing on implementing specific recommendations from the mental health policy. Our focus is on prevention, early intervention, and recovery, particularly in youth. And one of our main goals is to find barriers to implementing the policy recommendations outlined in Sharing the Vision, and then ultimately creating blueprints that are designed to overcome these barriers in partnership with people with lived experience of mental health difficulties. And so patient and public involvement is a core part of VISTA. We aim to have a non-tokenistic and impactful PPI process, and I will show you how we are taking steps towards a more impactful process. So just really quickly, I want to also go over the different work packages that we have in VISTA. So VISTA involves 6 work packages. One of the work packages is actually the public and patient involvement component, which is actually quite unusual for large grants like this to have a specific and separate PPI work package. The other kind of work packages focus on different areas of the mental health policy. So, for example, we have a work package on social media and youth mental health, physical and sexual health in youth, digital interventions in youth mental health, protective factors or personally modifiable factors for recovery from self-harm, and improving in the involuntary care pathway. Underlying all of these work packages is an implementation science framework. We are using the Consolidated Framework for Implementation Research by Schroeder. And so one of the things that we do in all our work packages is try to map barriers and enablers to implementing these policy recommendations based on the CFR model. If you're interested in learning more about VISTA, feel free to visit our website, which is over here, vista-apro.eu. Okay, so epistemic injustice is a concept which has really sort of catalyzed the movement for more lived experience and PPI usage in healthcare research generally, as well as in mental health care specifically. Epistemic injustice is the phenomenon of being devalued or not being trusted as a knower or a source of knowledge due to prejudice and bias in society. So that means having your communication undermined and just kind of being excluded, silenced, or misrepresented, and your lived experience and knowledge not really being taken seriously. This is really pertinent to mental health research because clinician, researcher, and other types of professional knowledge sources and methods of knowledge creation still largely outweigh lived experience knowledge and knowledge production. Another related concept is called participatory assimilation. So because people want to sort of reduce epistemic injustice over the past like 15 to 20 years, there have been more movements to increase the voices and the involvement of service users, patients, the public, people with lived experience within mental health research. And researchers are both choosing to and are mandated by national or funder policies to incorporate lived experience voices in the research cycle. However, when doing this, researchers often still kind of fall into the trap of something called participatory assimilation, which is when you involve individuals with lived experience in the research cycle, but only so long as their perspectives can be integrated or are supportive of the researchers' existing problem definitions and solution strategies. So as long as they kind of neatly fit into the existing structures and processes of research, and they kind of won't rock the boat too much, so to speak, they are more than welcome to be involved. But anyone outside of that, falling outside of that system, they are less likely to be included. So this is obviously a major problem because what ends up happening is that lived experience voices become very tokenistic as a result of this. And participatory assimilation is actually a term that was recently kind of written about in a paper by Feldmeyer and von Oos, actually published this month. So if you're interested in this concept, I would recommend that article. So why do we need inclusive and impactful PPI within mental health research? Firstly, to, of course, reduce epistemic injustice and tokenism. We want to challenge psychiatric stigma against people with experience of mental health challenges and redress power inequalities or inequities. We also want to allow the public and people with lived experience to shape mental health services through research. Inclusive PPI also helps support and foster ethical research practices. It boosts accessibility, engagement, and trust, and it improves research quality and promotes innovation. So I'm going to show you what our PPI process within VISTA looks like and some of the steps that we are trying to take in order to achieve meaningful, inclusive, and impactful PPI. So basically, we have a PPI panel, which I'll go into slightly more detail in a bit. We initially started out within the PPI work package by recruiting our PPI panel. And this, I'm going to go more into detail about the recruitment process and why that kind of helps foster a more inclusive PPI process as well. Another part of our work package is conducting a scoping review of barriers enablers to capacity strengthening initiatives for PPI contributors. Part of our PPI onboarding process was capacity strengthening training for PPI members as well as research staff. We are constantly adapting the PPI embedding process. So when our PPI panelists are like working with each of the work packages, how do we kind of design that process? That process is constantly being iterated. Upcoming stages in our work package are also process evaluation stages. So we are conducting data collection to find out how the PPI process is actually going at 3 different time points. And at the end of the project for our PPI work package, what we want to do is co-design a capacity strengthening program that we hope to pilot in recovery colleges across the country, a capacity strengthening program for PPI contributors in mental health research specifically. So how did we actually recruit our PPI panel? Firstly, PPI was kind of thought about very closely from the grant writing stage onwards. Of course, I was not involved in the grant writing stage, but there were 7 paid PPI roles that were written into the grant application from the very beginning. 2 of these roles were already filled by people who were involved in the grant writing itself, and then there were 5 more open roles that we were recruiting for. So last year in October, we started recruiting for these 5 part-time paid PPI roles to work on VISTA. The PPI panelist job description was co-produced with lived experience researchers. That was me and another researcher on the team. We had a multi-pronged job advertisement approach, so we actually cast a really wide net in terms of recruitment. We went to mental health recovery colleges, social community enterprise databases, migrant organizations, other NGOs and charities, and of course, academic and personal networks. We also had a non-traditional job application procedure. So basically, we didn't ask for CVs or cover letters, but we had a very plain language, brief expression of interest form that had a couple of questions, just asking people to tell us about their interest in VISTA and in research. There was also an in-depth shortlisting process that explicitly considered factors of diversity, so like different sorts of lived experiences and different backgrounds as well. Our interview process, we tried to make it as low stress as possible. So firstly, we sent everyone the interview questions beforehand. We sent people short descriptions of who the interview panelists were going to be. I was also involved. I was one of the interview panelists too. And there's an online interview option. We offered breaks during the interview if needed. Something that is kind of, I suppose, novel to the PPI process of VISTA is the unique employment structure. So rather than kind of having PPI panelists be sort of self-employed or like kind of be invoicing universities for payment, as it often happens, they are actually hired as part-time staff of a nonprofit called Mental Health Ireland, who are part of our grant as well. So they're actually employed as part-time staff or as external contractors, and they receive the benefits of being staff, such as sick leave, having a line manager, having a work email address, so that they can establish a separation from the university-based team members. And that also kind of helps diminish some of the power inequities that may arise. And then we had a gradual induction process with both PPI and academic team members. We didn't want to kind of foster a culture where it seemed like only the PPI panelists needed like extra training or like training in specific things, whereas the academic members had nothing to learn in the process. So some of the capacity strengthening initiatives that we did in the onboarding process was research literacy, personal narrative development, influencing and consensus building, and then relationship building workshops with where PPI panelists and academic staff were together. And the personal narrative development was one of those. And then only after this 2 to 3 month long onboarding process did we assign a PPI member to each work package. And then only then did they start working one-on-one with the PPI members. So what do our PPI panelists do? They are fully embedded into the research process at this stage. So they're involved in shared decision-making on various decisions of the particular research project that they're involved in. So they helped shape the research questions, write the interview guides if necessary, shift the focus of the work package, narrow down the focus of some of the work packages as well. They share thoughts on manuscripts. They attend online and in-person team meetings to discuss research projects. So whenever the work package team and the academic members are having a team meeting, the PPI member is usually there as well. They are helping to interpret research findings if they are interested in doing so. There are some PPI members who don't really want to take on that researcher role. So they're kind of open to being involved as much or as little in that sense as they like. And ideas on how to best share research findings with different communities. So that is something that will be coming up when we have more findings in VISTA. So briefly, we have 7 PPI members, as I said. 2 of those panel members are actually satelliting across all 6 work packages, so that one of them kind of acts as a PPI panel mentor and support, and then one of them is a general public representative who does not have lived experience or family member or carer experience. So each of the other 5 PPI members is working with one of the 5 work packages, and then they're employed for 2 hours per week for the entire course of the VISTA program. Some support structures that exist in VISTA are scaffolding of relationships in advance of beginning to work with the work packages, which was kind of done through the onboarding process. The PPI panel has regular supervision and team meetings, as well as informal check-ins. So they meet with the mentor PPI member, as well as a group once a month. And then we, as the work package team, are also available to provide guidance and assistance. And we also are putting an emphasis on strengthening the relationship between the PPI members and the postdocs on their specific work package, because they're the person that they'd be working most closely with. And a necessary component of equitable PPI is continuous monitoring and evaluation. So as part of this work package, we are conducting a process evaluation of our enactment of PPI. We're collecting qualitative data at the start, middle, and end of the program. So this consists of focus groups and interviews with the PPI members and academic team members, as well as reflective diaries that we're going to ask key members of the team to fill out. So the postdocs, the PPI members, and select principal investigators. Findings from this data will be used to adapt VISTA's PPI process through the course of the program, as well as inform the co-designed capacity strengthening initiative that I mentioned. So what are some of the highlights so far? We kind of started the onboarding process of PPI with the work packages in January or February. And so I would say they are probably around 5 to 6 months in working one-on-one with the work package teams. We found that due to the wide-ranging recruitment process, we could recruit panelists from diverse mental health challenge backgrounds, caring backgrounds, and people with a diverse set of research interests as well. And we could match them fairly well with work package needs. So the work packages also gave us a list of sort of qualities or traits that they would ideally need from a PPI member on their team. And then we kind of collected this similar information about the PPI members' interests, and we were fortunately able to kind of match up. But because we had over 200 applications for these 5 positions, we were able to recruit a very diverse panel. We find that PPI panelists felt more prepared and confident when contributing to the work package due to the gradual induction process. And the opportunity for rapport and comfort to be developed between PPI panelists and academics was really beneficial as well, and seems to really help the cohesion between PPI members and academic team members in the work packages. Of course, there were some challenges and learnings as well. So one thing that we learned was that there was a real need to map the needs of all the stakeholders before starting PPI recruitment, and this can help increase confidence in and commitment to the PPI process from all parties. So like I just mentioned, we collected a list of needs and a list of interests from academics and PPI panelists, and kind of tried to match them both. So we found that that actually allowed the academics especially to have more confidence in us as the PPI team, that we were working in their interests as well, and that we do really care about making sure that their work package goals are successful too. There's, of course, a need to build in flexibility within the work package, especially with regard to timelines. We all know like research timelines are, usually need to be kind of extended at some point. Yeah, so we've had to kind of build in some flexibility to conduct an equitable recruitment process. And we found that sometimes we needed to kind of extend the time that we spent on induction before kind of launching the PPI panelists into their work packages. We didn't want to send them in there feeling unprepared. And it was also important to balance the need for strengthening PPI member capacity in research skills with maintaining their non-researcher perspectives. So like I mentioned, there are a couple of people who are really kind of adamant about not being super, super involved in data analysis and data interpretation aspects, or like super like technical aspects of the research, because they've expressed the kind of hesitancy to do so because they don't want to lose their like outsider perspective. And that is an interesting but really important point to consider. I think sometimes when you're running a PPI process or program, people get so kind of wrapped up in making sure that panelists have adequate research literacy skills and that kind of stuff, that the uniqueness and like necessity of the external perspective kind of gets lost in that too. Okay, so I think I'm doing okay on time. I'm just gonna finish the presentation by talking about what it's been like for me as someone with lived experience of mental health difficulties to work on the PPI process and within the VISTA program. I also work on the involuntary care work package. So I'm both kind of helping manage the PPI process while also working on a entirely different research project too within VISTA. So navigating sometimes conflicting identities is a big part of the lived experience researcher role. I like this framework here, the Emerges framework by Gupta et al. And so these are sort of different positions of identities that lived experience researchers can have. You know, sometimes you're acting in your capacity as a professional, aka a researcher, postdoc, PhD student, or whatnot. Sometimes you're acting in the capacity of a service user. Sometimes these identities are integrated. Sometimes you find it difficult to integrate those identities as well. And so some background considerations as I tried to reflect on this experience for me was that I have lived experience of chronic mental health challenges for over a decade. I also kind of was educated in a culture of stigma or taboo around the disclosure of mental health challenges in professional settings. Like I did my undergraduate degree in America, and I was considering kind of applying to like clinical psychology PhD positions right after that. And something that they kept drilling into us in that was to never like kind of allude to the fact that you might be interested in clinical psychology as a career because of your own experiences with mental health challenges, which I thought was kind of ridiculous to say to people who want to get into this profession, especially because a lot of people have mental health challenges, regardless of whether they admit it to themselves or to others, you know, and it wasn't like, okay, me not saying that in a PhD interview was not going to make much of a difference to like whether or not I had that or whether it would affect my job as a clinical psychologist. So that was the kind of like general culture around this. I did my PhD in Trinity College, where I currently work. However, I had a challenging experience in that it was also during COVID. I had a traumatic experience in the middle of the PhD as well during COVID, which kind of made things much more challenging. So I kind of had an apprehension towards taking on other academic roles because of my previous experience. But nevertheless, I took a chance. And some of the highlights that I found was that the VISTA team has been so supporting, understanding, and validating throughout this whole process. I find that the agency I have over the disclosure of my own lived experience to be very positive. So, you know, I'm not kind of trotted around by the research team as, oh, here's our lived experience researcher. I'm the postdoc on these work packages. And if I choose to kind of tell people about my lived experience, that's up to me. There's also the drive of all the team members to model a more equitable process and a willingness to adapt, even if that's kind of goes against their like general or normal ways of working. People are still kind of very willing to adapt and try out this new process. And of course, the ability to connect with the PPI panelists on this lived experience component. Some of the challenges I faced, though, was this, again, pressure to conform to traditional academic mindsets and standards of productivity, even when I'm kind of struggling with my mental health challenges, the kind of need to keep pushing and pushing and not admit that like maybe you've reached your limit and need to take a break. And then that comes with like imposter syndrome and low self-esteem intersecting with other mental health symptoms. Another interesting challenge was kind of navigating the expectations of the PPI members that I work with and the limitations of academic structures. So kind of, they might want something to happen within VISTA that may not be possible given our resources. It's usually because of a lack of funding. So I might like very vehemently agree with them, but I also can't really do anything to change that or like make their fulfill their expectations. And then learning to ask for help or to say no, that kind of comes with the pressure to like be really productive. Again, that's the thing where you feel like, okay, if I say no, or if I like say that I am at capacity right now and I can't do this thing, they're going to think it's because of my mental health challenges and that I'm not capable of being a good academic because of these things. So, and I think those feelings are very common for people with lived experience, whether or not they have come out with that or they're, going through the challenges on their own. And that's pretty much it from me. So
Thank you so
happy
much.
to take any questions. I guess we're doing questions later. So
yeah, we do questions later, and what I've asked people to do is to write them in the chat so they will not forget them until later, because you're the first one. So thank
Sure.
you very much for this presentation.
Thanks.
So I will welcome the next speaker, and that will be Søren. If you are here, Søren, somewhere.
I'm here.
So welcome, Søren. You will talk about also your experiences as a researcher and chief researcher at Maskine Amager. And I think you will introduce yourself.
Yeah, thanks. Thank you for a great presentation. My name is Søren. I'm 47. I've been a patient for 30 years. I have a schizophrenia diagnosis and some substance abuse diagnosis and a diabetes type 1 diagnosis. And I'm just gonna present to you the Maskine Amager and our ambition to establish there our own center for patient-driven research. And I'm gonna share my screen with you here if I can, like so. I hope you can all see it.
We can see it.
Cool. Okay. Yeah, thank you for inviting me. And now I'm just gonna show it to you. The Maskine Amager, I established that with my friend and colleague Laugbe Petersen, the forensic psychiatric painter from St. Hans back in 2019. So we're almost 7 years old, and we're the patient's own place. And I hope this will, I'm just sharing my screen. I hope you can see this. This is our place. We got 600 square meters, and we filled it with creative activities and a community of mutuality. And we don't have medicine or coercion up here. We just have what you see. And then it's painting, it's graphic design, it's graphic printing, it's flowers, this is a gallery, all kinds of creative activities. And then this community of mutuality, and in average 46 people a day come to this place. We're open 9 to 8 every weekday. And these people are, well, they're like Nikolai and me. They have a so-called severe mental illness. And usually they also have other problems like substance abuse or homelessness or legal precautions or somatic illnesses, like I got diabetes. But and then they were isolated, they were lonely, but 46 people a day, it's quite a lot, and we're only ourselves. There are no health professional people up here. We are only what you would call peers or whatever. We're the patients helping ourselves. And we have been very good at this. So today, apparently, we stand as Scandinavia's largest and most advanced, truly patient-initiated and patient-driven peer-run recovery central. And well, we employ 15 to 16 part-time. We have 15 to 16 part-time employees. I think only one does not have a mental health diagnosis because she's very structured, our daily leader, and we need structure. But all other things we do ourselves, and we hire people on small-time positions to make creative workshops and these workspaces, teach art, teach community, and yeah, well, the only rule up here is that you try to give more than you take. It's called the help us principle. This is a memorial wall, by the way. It's called the help us principle, and you use it at AA and stuff like this. You come in and then you teach each other. And we try to be soldiers. We fight for this place, and we fight for ourselves, and we fight for society, both health staff and mental health system, and that perhaps this could be a more including world. And the production up here, of course, is great, and it's great fun. People become like brothers and sisters, and this place lives on far by its opening hours because people become friends, meet in private. And then here you see the house order, you give more than we take, and then you also receive more than we give. This is a place where we try to, I know my worst example, and it's not very pretty. And this is a place where we try to show ourselves from our best example. And thereby we gain friends, and we find meaning in running this place. And we're a civic organization. We're a small civic organization. We don't have anything to do with public services, and we're not a service. You come here to participate. You don't come here to be serviced. This was, I'm sorry, a very short, very short presentation. But I'm going to tell you a little bit why we decided to try to establish our own Center for Patient-Driven Research. The Maskine, by the way, it's machine. We're meant to be a small helping machine to the big public machine, and we try to assist with the things that the public system are not very good at itself. Well, okay, so what happened? These are our experiences. The first one I call Attack of the Leeches. And these involve health staff, journalists, and researchers. Because you must remember that the place we run down there, no one else is doing it. The public services cannot do it themselves. And the civic society they haven't caught up to this yet. So the first people that came were the health staff. We live in an old hospital building where the mental health center, Amager, have their outpatient clinics. And whenever they got a new colleague, they took that person over and, hey, look at what we have here. And yes, perhaps it's in your house, but you did not make it, and you don't own it. We do. And this is not your place to show. This is our place to show. And it's also an activity for us. And we have to make as many activities for us as possible, because doing stuff, being responsible for something, and is one of the ways that we actually get better. So it's not for you to show, but you can come in, you can be invited in, and then we will show you. Someone will show you. Then came the journalists, and they were looking for a place with fucked up people and a lot of authenticity. And they gave us cameras to document ourselves, and we did not like this, so we also told them to fuck off. I'm sorry. And then came the researchers, and the first ones were actually it's all the best example. There came the 2 postdocs and a movie director, and they wanted to apply for like €1 million to make something about us and artistic stuff, importance for mental health. And then they came up on the group meeting, and they had to explain their cause. And then all the questions came. It was like, what about all these violins when something is sad? Do you get to decide that? And yes, that's what there are things to decide. What about mythology? What are you going to write? And how are you going to portray us and stuff like this? And that was also for them to decide. And then the money, the funding, it went to their salary. We were just supposed to like be an object for their work. And then the final question came, why don't you teach us to make movies instead? But they had not planned that. So we told them no. And we had a lot of these people ever since, a lot of them. And I tried to devise a plan here, what it is that we don't like, and it's because they live in a completely different world from us. They're highly educated and belong to a higher social class, while we usually don't have higher education. And even if we do, we still belong to the lowest social class. We're not necessarily good and happy-go-lucky patients. Some of us won't be better. And they make a lot of money. They play tennis, they eat at restaurants and sleep at hotels. They often have great places to live. They have cars. They're influential. They have power to decide on their own lives and stuff like this. They're secure and they're healthy and they can take care for themselves and their children, and they are attractive and they can easily find partners, and so on and so on and so on. They live in a completely different world from us. But still, they want to extract data from us. They want to study us. They want to leech onto us because they haven't made this themselves. They want all the funding for their own salaries. They want to decide on the what, the how, the why, the who of the project. They want to decide everything. They think they're better than us. They want to be first, second, and even third authors and take all the credit for themselves. They want access to our space and to us, while expecting us to happily accept them, and that they could somehow, maybe the thought of disturbing our place has not occurred to them, but we feel that. And they feel entitled because they are who they are. And they present it to be some service to the common good, but they don't seem to do this PPI for us. We don't necessarily get anything out of it. We don't necessarily gain more from it than we give. And they don't want to hang out with us socially or in private. And I can perhaps understand this because sometimes I'm not very good at hanging out with. But they live in a completely different world from us. We tried anyway. We tried to patients' experiences with physical holding and mechanical restraint in psychiatric care and interview study. We did this because this was a good cause, and you could see me. I'm actually involved there as a co-author. I did interviews too. Then we did then we did this reacher involvement project. We had a mental health professional project where we wanted to try to employ mental health professionals at our place, and then we involved researchers to help us qualify the idea, and these are internationally renowned experts. Unfortunately, the project has not yet been realized, and this is because we are the patients. We have to do everything ourselves. But thank you very much for being involved in this. And then our latest thought is that we're building MMA's, our own Center for Patient-Driven Research. And this is because of the experience we have. Why do we not own this project ourselves? Why do we not do this work ourselves? Why do we not assist the common good with research from what only we have? Why don't we do it ourselves? So we have made this project, and it entails one of us who becomes a PhD scholar, trying to describe our place through 3 studies. And this is a participatory project, so it's not just this PhD scholar who will do all of it, but that's the person who are mainly in charge. And this person has to write 3 studies. And the first one is it's about the possibilities of participation at our place. And it has a research question on how participation enable recovery, and what significance this holds for people. And of course, we are our own data population, 46 people in average a day. And some of these people we're going to hire to to participate in this study. We're going to study some theory. It's something about situated learning and Goffman's role theory and Turner's ritual theory. And then we're going to apply a para-ethnological methodical approach, where we kind of investigate our own organization as to what people actually gain from participating in it. The second study is we want to know how are the working mechanisms at our place perceived to facilitate recovery, and who are the participants. This we would like to know. So we're going to make semi-structured interviews with all who wants to, and then we're going to subject them to reflexive thematic analysis as to what significance does the atmosphere hold. What about this user-driven community? What significance does it have? How do we actually succeed in doing what we are doing? I think that would be interesting because no one else is doing it. And who are these people who come here? And then the third study, it's a descriptive and a comparative study. How did we, as an organization and now as a research unit, a center for patient-driven research, how did we come about? How did we come to exist? And then compared to what other places like ours that exists internationally. And these are the 3 studies we would like to make. The PhD student will then be enrolled at the National Institute for Public Health and work out of Lene's psychiatric research unit down in Region Zealand and the MMA. And this is about the public health. It's because we think that what works for us, who are perhaps the worst off patients, some of the absolutely worst off patients, what works for us will also work for public health in general. And then the PhD student is also responsible for leading and coordinating the other participants of the project. And who are they? Well, it's a group of approximately 8 professional machinists. That's what we call ourselves up there. Research assistant researchers. They're going to serve as a user board for the project, the PhD project, and ensure its relevance, that this is actually relevant. And then they will also be researching on individual projects related to our place and to mental health services. And these can be a lot of things. Who knows what people will actually gonna study. And they're all hired on individual contracts, very small contracts, but still. And then we have an expert panel consisting of internationally renowned researchers to supervise the whole project and train us in validated methods, because of course we're writing about ourselves, but if we are taught validated methods, I think this research could actually be for something more than just ourselves. Yeah, I think my time is up also now. I don't know, a 4-year project, I think it costs around €500,000 in total. This has not been funded yet. I'm not a researcher yet, but I think it's a good idea. And I think it's something that does not exist anywhere else. And it's important. If research cannot come to us, then we have to come to research. We have to make it ourselves somehow. And this is a start. And yeah, that's pretty much, I think, what I had to say. Now
Thank you,
it's 8
Søren.
o'clock.
Thank you for presenting your
You're
big,
welcome.
very impressive project. And we
welcome.
can follow all your research questions and everything and the whole group. And I invite people to ask questions in the chat, so we will remember the questions in the end. And there are already questions for Shaakya in the chat. So thank you very much, Søren, for your presentation of Maskine. And then now I will give the word to Margherita from Italy. And you will talk about your master thesis. Is that true?
Yes. Hi, everyone. I'm sorry, my webcam is broke, so you're not going to see my face. I'm going to share with you my master thesis, if it does work. Wait a second. So I don't know, do you see the PowerPoint?
No, we see ourselves, or I can see myself, so you share the screen, not the PowerPoint.
Sorry, I'll try again. Now you see the PowerPoint? Okay, yeah. So
Thank you.
My master thesis was about studying the problematic use of social media and cyberpornography in relation to metacognitions and psychological distress. So as we know, we all live in this digital era, and it has redefined the boundaries of our human experience. So we can say that internet has become a psychological and a social ecosystem where individuals express themselves, their relationship, and regulate their emotions. However, this pervasive presence of the online world comes with a psychological cost. While the term problematic internet use is still debated, many researchers agree that it shares characteristics with behavioral addiction, such as loss of control, tolerance, withdrawal-like distress when the access is limited. In the last decade, the scientific communities has shifted from treating these phenomena as moral or social issues to analyzing them as psychological processes involving cognitive biases, metacognition, and maladaptive coping. So in this slide, you are seeing what problematic cyberpornography use and problematic social media use share with the behavioral addiction. At the moment, we only have gambling as a behavioral addiction. We do have in the last revised form of the DSM-5 a little section about gaming, but it's not yet recognized as behavioral addiction. My research used the IPACE model as a framework, a theoretical framework, and which conceptualized problematic internet use as the product of interaction between individual predisposition, affective and cognitive responses, and executive control. And the model suggests that individuals with specific vulnerabilities, such as higher stress or emotional dysregulation or dysfunctional beliefs, may use online environments to cope with the internal discomfort. Over time, these behaviors can become self-reinforcing through mechanism of positive and negative reinforcement. So in this study, we used two main variables investigated. The first one was the distress, that we can define as the experience in situation perceived as uncomfortable, unexpected, or unpleasant. And it results from the combined influence of stress, anxiety, and depression, and plays a central role in the regulation of the online behavior. We also studied positive and negative metacognitions. Metacognitions in general refers to the belief that evaluations about one's own thoughts, for instance, believing that worrying helps me stay prepared for like something, is like important to survive on a daily basis. For positive metacognition, we found out that positive metacognition are generally precede engagement with problematic behavior, functioning as the rationalization that encouraged use. And negative metacognitions emerge once the behavior becomes distressing or uncontrollable. The study had two different samples. We created two different groups. The total of the participant was 552, with more presence of the female population. We created the two groups by creating a filter question on pornography use over the previous 12 months. So in the group A, we just had participants who did not use online pornography and just use social media. The second group was created, as I said, thanks to this filter question about cyberpornography, and they were not used the information that we received from this group about the social media section. So these are the research hypotheses. They were the same for both groups. So we wanted to find out if higher frequency or time of use would correspond to higher levels of problematic behavior. We wanted to know if age would negatively correlate with problematic use, and if anxiety, depression, and stress associated with positive and negative metacognition will both increase alongside problematic behavior. And we also wanted to know if these cognitive and emotional factors would act also as predictors of the problematical behaviors. So these were the instruments that were used in the study. All the participants answered this question except for the cyberpornography addiction test that was like presented only to those who answered a yes to the filter question. And now I'm going to discuss you the results of the first group, the group of social media. So we found out that in our participants, we found a strong positive correlation between time spent online and problematic social media use. Age also correlated negatively with both time and problematic use. So we can say that younger participants were more at risk in developing social media addiction. Anxiety and depression and stress all showed as moderate positive correlation with problematic social media use, and also both positive and negative metacognition correlated with the problematic use, but the association was stronger for negative metacognition. These are the Pearson's coefficients that we found out in our study. And for the last hypothesis, we use a regression model, and we found with the regression model, we found out that the stress was the strongest predictor of problematic use, followed by a weaker effect for depression and positive metacognition. These findings suggest that stress, rather than specific cognitive distortion, may be the most immediate trigger for excessive social media engagement, supporting the idea that platforms are often used as a maladaptive emotional regulation tool. On the results of the cyberpornography sample, I must say that all participants display potentially risky patterns that a clear problematic use. And so our findings in this sample were less impactful than the ones that we found in the social media sample. We found out a moderate positive correlation between problematic use and frequency of consumption, yet the general level of problematic behavior, as I said, was lower than in the social media group. We did not find significant correlation between problematic pornography use and anxiety, depression, or stress, and only positive metacognition were weakly related to problematic use and acted as a weak predictor in the regression analysis that we also did for the cyberpornography samples. We can say that these findings indicate that in the domain of the cyberpornography, cognitive mechanism, specifically beliefs about the utility or harmlessness of the behavior, play a greater role than emotional distress. And participants appear to maintain a relatively regulated use, suggesting a nuanced boundary between a healthy sexual exploration and problematic consumption. These are the limitations of the study. The study relied only on self-report questionnaires that are really really exposed to bias such as underreporting or social desirability. It's a cross-sectional design, and so it precludes casual conclusions. Longitudinal designs are needed to clarify the directionality of the findings. And also there was a gender imbalance with the predominance of the female participants, and it may have influenced the the findings, particularly regarding pornography use. So we can say that we also have interest in exploring additional dimension of the metacognition, because in this study we only focused on positive and negatives one. And also we think that we should maintain the focus on adult population, because a lot of research that has been done in this field is focused on the teens, so the adolescents, and there are very few studies on adult population, especially the young adults who grew up with the first social media, and by studying the young adult we can find if there is long-term aspect on the mental health that has been influenced by prolonged the use of the social media. And also nowadays, as we know, soft porn content are also accessible on the social media platforms. So, and it like makes defining what cyberpornography really is more difficult, because it's not just pornography sites as once was, but now we also have in the research we found out that a lot of people used pornography, for example, on Instagram or in Twitter or X or Telegram. So it's limited, focusing just on the on the pornography sites as we know them. And yeah, that's it. Thank you very much.
Thank you so much, Margherita. And I know that you're a living person, even though we haven't seen you. And I think it's important also to answer your question, Katie, as well. But of course, everybody is saying that everything is thank you for the presentations and things like that. And Lisa is asking, how did you map or suggest mapping stakeholders' wishes, needs before including PPI?
Yeah, great question. And thanks to the other presenters as well. I did really learn new concepts that I hope to apply. It wasn't a complicated, like we didn't use like a complex process or anything. It was, we wanted to acknowledge that work packages did have specific kind of goals in mind for, and deliverables that they needed to produce by the end of the grant as well. And we had been getting questions about like, do you know what the PPI panelists are going to be like? Because, you know, the population or target population of each work package differs as well. One of them is dealing with social media and how young people use social media positively. Another one was dealing with like self-harm, that kind of stuff. So we saw that there was kind of maybe a need for their needs to be heard by our team. We just kind of asked each team to put together a list of potential characteristics that might, in a PPI partner, that might benefit their project. But at the same time, we did very clearly kind of boundary that by saying like this was not like a wish list necessarily, or it wasn't, we weren't going into the recruitment process with that list and trying to like select candidates based on that. We were selecting candidates through a completely independent selection process. And then after we had chosen our 5 final candidates, only then did we go back to the sort of characteristics that each team had put together and then tried to match PPI panelists to each of the 5 panelists to the work packages based on their what like the work packages thought they needed. But we also asked the PPI panelists themselves, when they accepted the job offer, to rank the work packages based on their level of interest in them. And then we went through a process of making sure that each PPI panelist got assigned to the work package that was either their first or second choice ranking, basically. It just so happened that generally PPI panelists were generally able to kind of fulfill the criteria or the characteristics that would benefit their specific work packages. Sometimes on the surface, at the beginning, it may have seemed that, oh, I don't know if this PPI panelist is a good fit for our work package because they don't fit necessarily the demographics of the target population of the study, but that's not necessary to have a good, like, impactful working relationship with the PPI panelists. And in fact, that work package is doing extremely well. They have a very close relationship with their PPI panelists as well. So
thank you so much, Shaakya, for this informative description. And I was just thinking about you, Margherita, because your research was in relation to the social media. And Shaakya were talking also about panelists involved maybe in the social media. When you were thinking about your project, would there be anything? Would there be a panel that should discuss your results in order to inform the knowledge or make new questions? Or what do you think when you have been listening to Shaakya's presentation?
For me, it was really interesting because the idea behind my research was actually my lived experience with social media when I was a teen, and how not so good use of the social media made me consume some kind of content that were not so safe for my mental health. So I think that having maybe some, I don't know, panelists that did have that kind of experience, with a negative experience with social media, and had been impacted by social media as a maintaining factor of the mental health, can be very interesting in educating, for example, teens in a correct use, and inform them about the risks, because the algorithm is really, really good in some ways, but also bad, because the more you consume something that is not healthy for you, the more kind of content it proposes you. So having someone that actually teaches you and supports you in using social media in the correct way, I think it's a really strong resource, actually. Yeah.
Yeah, thank you so much. There's a question from you, Katie. I will just, or maybe you will say it again. How do Panaki theory apply to research? And you ask maybe all of us, or maybe you ask the panel. And I don't know if any from the panel, Søren or Shaakya or other, can reflect on that. Me myself have to understand it better. I think it was very inspiring, and I like the pictures with the nature and the healing nature and things like that. And but I have to dive more into the theory. I don't know if could you ask the question again, Katie?
Sorry, with the question that I asked at the end of the presentation was just how if people could see whether or not it might apply in their research work that they're doing. I guess that was the question, and I can see you asked in the chat function, Lena, were you asking me how I applied in my research, or were you?
I just asked people so they remembered your question, but there is a question from Eva. Thank you for your inspiring presentation. What research approaches are you planning on using?
So my aim is to develop a digital tool for helping people and clinicians to do supported decision making in mental health treatment planning. And so that's a design project, and I'll be co-designing it with a group of people that include people with lived experience of mental health challenges, with peer support workers, and with clinicians. And we also have ethics approval to undertake a number of surveys as well that will inform our design process. So that's the approaches that we'll be using very briefly.
Thank you very much. So it sounds really like you are, if I hear you correctly, you are thinking about quantitative methods for panarchy theory application. That will be a rare treasure, I believe, yes?
It will be a mixture of both, yeah, qualitative and quantitative. So it will be really interesting to see how that goes. And I'm still working out how panarchy might apply in my own work. So that's a bit of a work in progress, I guess. Yeah.
Thank you. Crossing fingers. Very interesting. Thank you.
It's very interesting. And Søren, you also got a question from Lisbeth, and you told about your insider perspective, and you wrote that people can write you questions, but I don't know if you have any elaborations on your research after you have listened to the other researchers who were doing research with the lived experience and as of new and young researchers.
Yeah, Lisbeth asked how we were going to manage the lived experience in this project, and I think the lived experience will be involved in several stages. First, there's this PhD who has lived experience. Secondly, there's what you could call a user panel, people who have lived experiences, but who also wants the responsibility for making sure that the project stays relevant, that this is actually something that this place of ours could be in need of. Then on a third level, there are they write their own material, and these are people who might have a BA they did not finish, or a MA they did not finish, and they will finish these projects, but in the context of our place. So perhaps if a person has studied social governance, this person will write his thesis on social governance and something for the patients. And these lives there are plenty of, and some of them need to finish their studies, and they will do it in our range, but they will then have to find their own supervisors in their own schools. Also, the fourth level, we will hire what you would call machinists of our own, people who wants to participate in research, who wants to be a part of investigating our own organization. How it will actually be handled financially, the money for this is a part of the project, and then they will be employed on individual contracts, and they will be led by this PhD student who they know and who are one of theirs. And then it's about developing validated stuff, their own projects. They must be their schools must qualify them or stand for them, but we'll pay them to write them. And for our sake, what we will do will be in validated research methods, and we will be trained by this expert panel advisory group, and the PhD student will have 3 professor supervisors. I don't know if this answered Lene's question, and the complete details of it can be retrieved by me by writing, and you're welcome if you have any other questions.
I will hear out there in the audience if you have any other questions or discussions or elaborations on this topic. Then I will go back to where I began, because I hope if I can find the right window. Yeah. I just talked about in the beginning the new project or big thing that is happening in Europe called PRISM, Mental Health Joint Action. I showed you some PowerPoint in the beginning. And this is about what we've been talking about today, how we are not only implementing best practices from different European countries to work with the mental health in Europe, but also how we invite voices from people with lived experiences into the debate. And when I posted this webinar, I told this group, you can see here on LinkedIn, and you can join the group, that we had this meeting today, and there will be a lot of people from all over Europe, different countries and organizations. And as I told you before, the most important thing is to, one important thing is to make a recommendation for how can Europe use this expertise in a more unified way. And if they had been listening to you today, which I had hoped, but now I have been listening to you, and I hope that I can use all what you've told about the way you are working in Ireland, the Maskine, Australia, all your experiences. I can tell about them because I've heard them, but they may also learn about all your projects, because I think we have good practices when you are telling about them, and they are very important. But you can go into this on LinkedIn and follow what happens. It has just started here a month ago, so there will be no result yet, but we hope that this will be something that will spread out over Europe over the next couple of years. So that was just my final words. Thank you to all of you who participated today. You are talking directly into the agenda, I think, in the world, and what Inter wants, the network we are collaborating in and trying to organize these webinars. And yeah, I think this is the future. So thank you so much for your presentations.
Thank you for having us.
I'll put the link in the chat so that if you want to join the LinkedIn. So thank you. And in Denmark, the time is very dark outside. It's not dark. Maybe it's morning in Australia, Katie.
4 o'clock in the morning.
Oh, 4 o'clock. You have to go back to bed. Jakob, yeah. Did you have no? So thank you for today, and you will hear more from us another day, or maybe we will contact each other on another occasion. Bye-bye.
Bye.
Bye. Thanks.
Bye. Thank you.